first place, I'd just like to bring to your attention the fact that our healthcare policy is unique in the world, and I'll amplify on that in a couple of minutes. But it's also an example of a public policy dilemma that we have in this day and age. Things are changing so rapidly, so dramatically, that public policy considerations are not keeping pace with the changes, so as to take into account the consequences of the changes that are taking place. I'll give you an example, the most vivid example I can think of. The 2008 fiscal meltdown that we almost had. We should not have been surprised. The fact is that we were applying laws and policies from the Depression era, the 30s. We were trying to apply those to new esoteric financial products, credit default swaps, interest rate swaps, things of that sort. And we're not surprised it didn't work. Healthcare area is similar in some respects. Our system is largely a system of employment-based healthcare. That's a policy that comes from World War II. When we had wage controls and price controls, employers wanted to attract candidates for their employment positions, and so they offered them benefits. Biggest one being healthcare benefits. The federal government thought that was a good idea, so they went and changed the tax code so as to facilitate that sort of thing. Well, that was a great policy, even though it rolled the cost of healthcare into the price of products and services in the 50s and the 60s because we had no competition. Well, as we all know, we have lots of competition at this point. And so no other industrialized nation in the world finances healthcare as we do, rolling the cost of healthcare into the cost of products. That leaves our people at a competitive disadvantage that is huge, particularly our manufacturing people. So there's a wonderful example of where we have to bring our policies up to date. That's what ACA purports to try to do. It rejects the concept of fee-for-service payments, saying that really we should switch over to an outcome-driven reimbursement system. In other words, quality over quantity. The second point is to provide greater access to primary care, specifically with regard to chronic diseases, asthma, diabetes, heart conditions, things of that sort. These conditions are all preventable. They're all manageable. They spend lots and lots of our money. 70 cents of every healthcare dollar goes to dealing with chronic diseases. Primary care can avoid some of those consequences and some of those difficulties. Data-driven formulation of best practices to learn what works, using new types of technology, new types of electronic medical resource technology is the key to that. Then lastly, and you heard a little bit about that a couple of minutes ago, more coordination and collaboration between the healthcare providers particularly. The assumption being that if we can reduce costs through outcomes that are better, that's something we should be doing. I'm cautiously optimistic it's going to do well on the side of access to the system. We're going to be insuring another 30 million people by virtue of this bill. And we're on the road to be able to have universal coverage. Universal coverage is desirable not just for humanitarian concerns, but as a cost concern as well. Because now what we have is people that don't have coverage show up at the hospital emergency rooms, the hospital have to eat the cost, or taxpayers provide for uncompensated care, or it gets rolled into the rate base of the hospital. And therefore all the insurance payers have to pay that cost. So I think access is a good thing for us to be looking forward to a successful outcome. On the whole idea of quality, this whole idea of outcome-driven reimbursement, the whole idea of outcome-driven provider provisions of new best practices. Those things are good, and I think that's good. On the cost side, there's some apprehensions I have, and if we have questions and answers later on, I'll be happy to go into it. But I'm just concerned about some structural deficiencies in our economy that will cost more than we expect to have. We can't go too much more than 18% of gross domestic product with healthcare. So there's a need for us to go and revisit this perhaps if things don't work on the cost side.